All right, so another unit for measuring the distance between RR intervals is the 1500 method. This is the most accurate, typically used for heart rates in excess of 150 beats per minute, and it can only be used on regular rhythms. So we're going to count the number of small boxes between any two QRSs of the complex and divide between 1500. I can just round up with these. So we have 5, 10, 15, 23. So 23, we are going to divide that by 1500, and that number doesn't give it to us. I'm not gonna do that. Dysrhythmia classification, so we have, that's not good. Perfect. Cardiac dysrhythmias can be induced by many events. Many of these can be traced to ischemia, especially the cardiac conduction system. Dysrhythmias are the most common cause of cardiac arrest, and dysrhythmias are classified in numerous ways. So there's disturbances to the automaticity or the disturbances of conduction. Tachydysrhythmias or bradydysrhythmias in life-threatening, non-life-threatening by the site from which they arise. Some rhythms originate in the SA node, so you have normal sinus rhythm, an intrinsic rate between 60 to 100. I know we talked about that. And with regular rhythm and minimal variations between the RR intervals. The upright P waves that precede each QRS complex, there's a PR to 0.12 to 0.2 seconds or 120 to 200 milliseconds. That's going to be normal. In QRS complex, we want to have anywhere from 0.11 seconds or 110 milliseconds to less, typically 0.08 to 12. For sinus bradycardia, there's a rate of less than 60 beats per minute. An upright P rate precedes every QRS complex. The PRI is anywhere from 0.12 to 0.20 seconds, and our QS complex is going to be 0.12, nice and tight. Very slow heart rates lead to inadequate CO and precipitate heart electrical instability. I got to figure out that CO means carbon dioxide if it needs to be CO2. Our ectopic pacemakers in the AV junction or ventricules may fire and produce escape beats. When these sinus rates become very slow in healthy adults, the conditioned athlete's sinus bradycardia may be asymptomatic and may occur during sleep. That is why I had to go see a cardiologist before I got hired as a firefighter, because they didn't know if mine was asymptomatic or not. I had an extremely low heart rate I'm at 53. I thought I'm pretty excited right now, but I'm at 53. If I'm not doing anything, I'm like 46. Rhythms originating in the SA node. What could cause these? You could have altered mental status, ischemic chest discomfort, acute heart failure, hypotension, and treatment is indicated when these signs and symptoms persist despite adequate airway and breathing. So management for symptomatic bradycardia. We want future goals for emergency care, so maintain adequate oxygenation. We want to ventilate, perfuse, and we also want to correct the rhythm disturbances and restore stable perfusing rhythm. Search the underlying cause for which may cause hypoxia. This could be hyperthermia, shock, AMI, AV block, toxin exposure, beta blockers, calcium channel blockers, organophosphates, digoxin, electrolyte disorders, increasing the intracranial pressure, or other factors. Administering emergency medical care, we're going to maintain an open airway, assist the breathing as necessary, and administer supplemental oxygen that's needed to maintain an SpO2 of 94% or higher. Check your own protocols for that. Apply a cardiac monitor, and we're going to get a 12 lead. We want to check the pulse oximeter, the blood pressure. We want to establish IV infusion through normal saline, so we're ready to go with any medicine should we need it. We want to obtain a finger stick, get the blood glucose Hacky check, and hypoglycemia if that's present. Also administer atropine, that's good for bradycardia, IV bolus for symptomatic sinus bradycardia, or conduction block at the level of the AV node, and repeat atropine every 3 to 5 minutes until the desired heart rate is achieved, or until the dosage limit of 3 milligrams has been achieved. So no more than 3. If atropine is ineffective and the patient's symptoms are still hemodynamically unstable, persist, then consider transcutaneous pacing. So we ran out of meds, now we're going to buy electricity. This is going to be the most invasive method, but it is the one that could make the difference. And then once we're done, we could also administer dopamine or epinephrine infusion for vasopressors. So we're going to transport the patient for definitive care at the end of all of it. So this shows the treatment guidelines for adult bradycardia. We're going to assess appropriateness of the heart rate, typically less than 50 per minute. That's going to be your bradycardia. So we want to identify and treat the underlying cause. We want to make sure that they're breathing. We want to get a 12 lead. We want to oxygenate if necessary, and our 12 leads are monitor pulse ox, BP, see if we have persistent bradycardia and if they're unstable. What would unstable look like? Maybe they have altered mental status, hypotension, signs of shock. They could have acute heart failure or ischemic chest discomfort. If they don't have any of these, we're going to monitor and transport. If they do, atropine. Atropine, we are going to give a dose of 0.5 milligrams, all the way up to 3, and we're going to give atropine every 3 to 5 minutes, see what that does for that. If it doesn't work, then transcutaneous pacing it is. We could also give dopamine, or we could give an epinephrine infusion. If we're going to do dopamine, we're going to do 2 to 20 micrograms per kilogram per minute. In a 100 kilogram patient, if we're going to give, let's say 10, we are going to give 1,000 micrograms of dopamine. 10 times 100 per kilogram per minute, yeah. So we're going to give 1,000 micrograms. What is that? 1 milligram. We're going to give 1 milligram of dopamine per minute. Epi infusion, 10 micrograms per minute, same. So that makes that pretty easy. Artificial pacemakers. Patients could have a transcutaneous pacemaker depolarize the myocardium by delivering electrical energy through the skin of the chest through an extrinsic method. Capture is usually going to be associated with ventricular depolarization. The characterized by a wide QRS complex in the ECG should result in a corresponding pulse. We're going to use transcutaneous pacing for the following situation. If a patient with bradycardia has a severe reduced CO, then they might not respond to atropine. The patient who requires interhospital transport or pacemaker implementation. The symptomatic patient with an artificial pacemaker failure, and to properly initiate transcutaneous pacing, what we'll basically do is we are going to capture the rhythm. Once we hook up the pads, we're going to find the beat. It's going to find it somewhere right before the QRS. That's the highest amount of electricity that someone's going to be delivered. And to get there, we are going to adjust it to around negative 70 milliamps. Once we have it, we're going to hold the sync button, sync up, and we are going to hold the shock button and make sure that we're delivering enough shocks. If the patient's, if the shocks aren't working, we might have to up the voltage to 120. Sinus tachycardia, we have the rate of 101 to 180 beats per minute with regular rhythm. The upright P wave precedes every QRS complex. The PRI is 0.12 to 0.2 seconds, and the QRS complex is nice and tight at 0.11, 110 milliseconds. This could result from pain, fever, hypoxia, hypovolemia, exercise, and stimulation of the sympathetic nervous system or pump failure. Hypoxia, metabolic acidosis, hypokalemia, and hypocalcemia due to electrical instability. Sinus dysrhythmia. Slight variation in the cycling of sinus rhythm, usually exceeding 0.12 seconds or 120 milliseconds between the longest and shortest cycles associated with respiratory cycle fluctuations. So yeah, so the P wave precedes every QRS complex. The rate is increasing and increases during inspiration, decreases during expiration. This is for dysrhythmias that originate in the SA node as well. An upright P wave still precedes PRI 0.12 to 20. Often found in children and young adults, it tends to diminish with age. So more prominent with respiratory cycle. I have this. Sinus arrest. The SA node fails to initiate an impulse, which eliminates the P wave, the QRS complex, and the T wave for one cardiac cycle, and then removes normal functioning. The atrial and ventricular rates usually begin with normal limits and regular rhythm, except for absent complexes. The upright P wave precedes every QRS complex still, and the PRI, when present, is 0.12 to 0.2. Sinus is pretty normal. Possible causes of this could be ischemia of the SA node, could increase vagal tone, could be increased vagal tone, carotid sinus massage, the use of drugs such as digitalis and quinidine. Occasional episodes, not significant unless the heart rate drops below 60 beats per minute, because then we're going into bradycardia. Treatment may include a temporary pacemaker in the field or a permanent pacemaker placed in the hospital. Sick sinus syndrome, a variety of rhythms involving poorly functioning sinus atrial nodes, commonly in older adults. Patients may exhibit syncope, dizziness, palpitations, or may have no symptoms at all. It is shown on the EKG as sinus bradycardia, sinus arrest, SA block, and alternating patterns of extreme bradycardia and tachycardia. Rhythms originating in the atria, so you have impulses in any area in the atria. Upright P waves preceding each QRS complex, or P wave is the atria. When they are not well-rounded, those generate from the SA node. Premature atrial complexes are PAC. So this is an ectopic complex that is within another rhythm. An upright P wave precedes the QRS complex, but its shape differs from the P wave originating from the SA node. Our PRI is 0.12 to 0.20 seconds, and it may vary slightly. Our QRS is 0.11, nice and tight. So you can see right here we have a regular rhythm, something happens right here. First cue, let's look at our interval. So we have 1, 2, 3 squares. If you move this back, that's 3 squares. If we go here, 1, 2, not 3 squares. That's almost rounded down to 2 squares. You could pull that back, that's almost 2 squares. So this is our ectopic. Ectopic means something that's where it's not supposed to be at, like an ectopic pregnancy. So premature atrial complex. Rhythms originating in the atria, so not always conducted to the ventricles. A non-conducted PAC is the presence of a P wave that occurs early in the ECG and is not followed by a QRS complex. Very common and can be caused by stress, stimulants, caffeine from condition, heart failure, electrolyte imbalance. Treatment is focused on by correcting the underlying cause. So we have supraventricular tachycardia. It originates in the site above the ventricles. Supra meaning above, supraventricular, site above the ventricles. Ventricular rates are faster than 100 beats per minute at rest. That's not normal. In a patient that normal ventricular function, tachycardia with a rate of less than 150 beats per minute is rare and serious signs and symptoms. The ventricular filling time is greatly lowered when ventricular rate exceeds 150 beats per minute, which is going to reduce our CO. What is our CO? Gas exchange? Cardiac output, that's what CO is. So it reduces our cardiac output. I've been saying that wrong for so many of these videos. Damn. All right, so 150 beats per minute. Think of, filling up a bike tube, right? Like if you're extending your bike tube all the way, you're filling up all of that air to then push into the bike tube. If you're going too fast with it, I mean, I guess it's pressurized, so really it's kind of a bad analogy, but if you're going too fast, that air isn't filling up enough of the bike tube because it's not giving time for the air to rush in before it preloads to inject. So same thing with the heart. If you're beating too fast, your heart's not getting as much cardiac output. There's not as much blood flowing into your ventricles because they're beating so fast. Same thing happens if you're doing push-ups or pull-ups. Pull-ups. Everybody always roasts each other on pull-ups, right? When you do pull-ups too fast, you're not really doing pull-ups at all, right? You're just kind of like vibrating in the air. Same for push-ups. If you see someone do push-ups too fast, unless they're flawless, they're going to say they're not doing the actual push-ups. So that's probably a better analogy. When the ventricular rate reaches 150 to 180 beats per minute, the P wave, if present with SVT, tends to completely be obscured by the T wave that's preceding the beat. PRI cannot be measured until the heart rate is lowered. QRS complex is 0.11 seconds. Most common is called the AV nodal reentrant tachycardia. Under conditions like the presence of myocardial ischemia is a premature impulse that can trigger a series of rapid beats. These impulses could get stuck on a repetitive pattern or generating multiple ectopic beats at a very rapid rhythm. This treatment depends on the severity of the patient's symptoms and may include medication or electrical therapy to slow the heart rate. This figure shows the process of reentry, spread of impulse through tissue that's stimulated by that same impulse. So this is our area of depolarization. Electricity fires, and then it follows a bunch of the conductive cells to come right back down to where its original area was. I think that's what that's saying. Note the following for management of tachycardia with a pulse. So our goals are emergency medical care include to maintain adequate oxygenation, ventilation, and perfusion. Correct the rhythm disturbances and restore a sinus rhythm. Search for the underlying cause such as medications, caffeine, diet pills, thyroid agents, or decongestants, illicit drugs, cocaine, amphetamines, and heart failure or a history of dysrhythmias. If the patient is stable and exhibiting signs related to tachycardia, therapies such as vagal maneuvers and medication is recommended. If unstable signs, symptoms are determined to result from tachycardia, use electrical therapy with synchronized cardioversion if they're unstable because they're about to collapse. Follow the recommended treatment for adult tachycardia as long as they have a pulse. This is not pulseless electrical activity, which would be PEA. So we're going to assess the appropriateness of the clinical condition to assume tachycardia. That's going to be over 150 beats per minute. We want to identify and treat the underlying cause. So we want to make sure that they have oxygen if they're hypoxic. We want to use our cardiac monitor to read their blood pressure, pulse ox, and we want to maintain airway as well. If they are stable or unstable. So persistent tachycardia, is it causing hypotension, dropping blood pressure? Do they have altered mental status, any signs of shock, ischemic, chest, or acute heart failure? Same as our bradycardia. Now we're determining if they have a wide QRS or not. So if it's greater than that 0.12 seconds, if it looks like there's more surface area in there that's taken up, we want to get IV access and 12-lead EKG.